Good morning, everyone. Can everyone hear me? You can just say yes in the chat box before I proceed. Nice. Welcome to the second annual MRL Research Conference. I'm your host, Dr. Qbel Tesfaye. Today is the first day of the 2 days conference. Today we'll have a research proposal presentation for the Pacemaker Research Grant. We'll have 3 presentations. So we'll spend around an hour and a half. So we'll have an opening speech, 3 presentations of the proposals, and comments from the reviewers and the audience. And we'll have a closing ceremony with the certificates. So before I proceed with the opening speech and the presentations, I want to tell you a little bit about this Pacemaker Research Grant. This is the second one. And it is intended to foster a new generation of researchers, clinicians, by providing them the necessary knowledge, skill, and resources to help them carry out problem-solving researches and contribute to Ethiopia's journey toward this evidence-based clinical practice. So this award recognition element is a grant of 50,000 Ethiopian birr, and also a full consultation support from MRL in the proposal development, in conduction, and publication of the research. I think more than the money, this consultation, a full consultation and support will help the researchers in achieving their goal in these research proposals. And as you know, MRL has supported over 30 peer-reviewed articles, which are published in a peer-reviewed journals, and also successfully advised over 200 thesis workers for master students, residents, and also fellow and residents in Ethiopia and abroad. So without further ado, I will introduce our first guest who will open today's session for us. It is Dr. David Woldai. Dr. David Woldai is an associate professor at McMaster University in Hamilton, Canada, and also a senior researcher in EPHI. Dr. David Woldai is trained as a medical doctor from Gondar College of Medical Science in 1987, and also obtained his MSc in medical microbiology. And also he has obtained his PhD in immunology from Karolinska Institute in Stockholm, Sweden. And he has ample experience in training and mentoring masters and PhD students, and is currently promoter for the 3 PhD programs. He has served as an editorial board and reviewer of several scientific journals, including the Lancet's Global Health, AIDS Research, PLOS ONE, and many more. And Dr. Woldai has received several research grants and also published over 150 scientific manuscripts in peer-reviewed journals, and also 2 book sections and several manuals. So for further detail, I will leave on a link to his bio. And without further ado, I will leave the floor to Dr. David Woldai.
Good morning, everybody. Can you hear me?
Yes, we can.
Yeah, thank you. Sorry, it's 7 a.m. in Hamilton right now. It's good afternoon in Ethiopia.
Dr. David, I think we've lost connection with Dr. David. Will proceed as soon as he comes back. At the meantime, I will share you the posters that we have prepared to be shared while the presentations are going on. So we have 7 research posters prepared by our members. Let me share it with you. We'll proceed as soon as Dr. David is back. I think Dr. David is back. We'll leave the floor for them. We can't hear you, Doctor. You're muted.
Okay, I'm back. Sorry for the interruption.
No
I
problem.
don't know what happened. Anyway, what I was trying to tell was that Tigis has done a very marvelous job in creating this research, forum for everybody at a private level, and really it takes a gut to initiate such kind of activities. And also, I'm very happy to see myself being a medical doctor background, to see that engagement of medical doctors in research recently in Ethiopia. In the research work I do with EPHI and also other universities within Ethiopia. This is really encouraging because most of us are inclined to clinical practice and would really like to engage in clinical work only, but having now a very substantial number of physicians engaged in research work is really exciting as well as encouraging. I don't know how, I do not have a lot of time to share my experiences with you, but briefly, I can mention when I was a young physician working in Aksum as a general practitioner, I faced a 12-year-old boy who came to the hospital with coma. And then there was malaria pandemic at that time in Aksum. This was like 32 years back from the place where this kid came from. And we did blood film. And one of the person whom I respect in my life, a very senior lab technician, Mr. Aragai, did a blood film, and he told me that the child has Vivax malaria. I went back to the lab, discussed with him, took again another sample because I didn't trust. I have a kid presenting with coma. Then my diagnosis was falciparum malaria with cerebral malaria. Then we reviewed the slide again, took another additional sample and confirmed that it was indeed Vivax malaria. Then I went back to my patient, then did examination, thoroughly from the head to the toe, as they say. And I don't know, for gut feeling, I decided to do lumbar puncture. And it was unbelievable. There was pus, did gram stain, and it was meningococcal meningitis. I still have the case report written in handwriting. like a case of meningococcal meningitis with vivax malaria mimicking cerebral malaria. And if we were not able to get the diagnosis correctly with the help of our brave lab technician, Mr. Aragai, we would have killed the patient. We would have missed meningitis, and we would have only treated malaria, and then the child would have died or developed complications following meningococcal meningitis, as you are already aware. I think this was one of the earliest things in my career that made me interested to pursue research. And then I did my medical microbiology studies at Black Lion Hospital with one of my friends, Professor Daniel Asrat, who is going to be one of the reviewers today in today's session, and then did my PhD immunology, Karolinska Institute in Stockholm, Sweden, and have been working at EPHI in state-of-the-art molecular technologies, diagnostics, infectious disease. And more recently, we are engaged, 30% of my time, I'm engaged with EPHI and 4 or 5 universities within Ethiopia, where we try to build capacity for young PhD, the postdocs to McMaster to train on pathogen genomics and proteomics. In the project that we are currently running in Ethiopia, it's called EpiGen Ethiopia, which is trying to develop pathogen genomic sequencing for emerging infectious disease of priority diseases. Right now, we are doing, sequencing of dengue. Dengue has become also a major public health problem in Ethiopia. You remember everything fever previously was supposed to be malaria, but there are a lot of things to consider these days in the differential diagnosis of malaria, of acute febrile illness or fever of unknown origin. We also have identified a very unique leishmania that has never been reported from Somali region recently, cutaneous leishmaniasis due to Leishmania tropica. We just sequenced 10 full genome parasites isolated from the skin. We are also dealing with cholera genomics, salmonella genomics, and we're trying to do also genomics on Mycobacterium tuberculosis along the Rift Valley region, where MDR tuberculosis is emerging as a potential public health emergence. So I wish you a great deliberation during the during the next two days in these interesting presentations from which is kind of interesting because it's a mix of presentation, both from practitioners, medical doctors, as well as biomedical scientists. Kind of exciting, including surgery. I was even surprised to see articles, papers going to be presented in surgery, which is really encouraging. So thank you very much. If you have any question, I'd be happy to address, and I wish you great deliberation for the next 2 days. And I declare that this MRL second annual conference is open. And I thank Tegist for inviting me to deliver the opening speech. Thank you very much.
Thank you, Dr. David, for this wonderful opening speech. And as you have mentioned, we have very distinguished guests who will be our reviewers and also speakers in these 2 days event. So I'll make sure to drop their LinkedIn profile so that you can follow their works and also their bio. It will serve you as a motivation and also will help you connect with them depending on your research interests. So our first presenter will be Dr. Eden Teferi, who is a general practitioner in Meshwalaka Health Center, and she will be presenting her proposal, which is titled Pattern of Diagnosis and Treatment Challenges of Autism Spectrum Disorder at Government Hospital in Ethiopia. So without further ado, I'll leave the floor for Dr. Eden. She'll have roughly 10 minutes to present her proposal. At the meantime, while we wait for the reviewers and Dr. Eden, Dr. Eden, can you hear me? Are you here?
Yes.
All right. All right. All right.
Can
We'll leave the floor for
you see the PowerPoint?
Yes. Yes. Yes, we can.
Okay. Thank you. My name is Aidan Tafari, and the title of our proposal is Patterns of Clinical Presentations, Delay in Diagnosis, and its Associated Factors of Autism Spectrum Disorder at Governmental Hospitals in Ethiopia. This is the outline of our presentation. And introduction, autism spectrum disorder is defined according to the DSM-5 text revision version is a neurodevelopmental disorder.
Aiden, you're muted.
Can you hear me now?
Yes, yes, we can.
Okay. So in a systematic review, the global prevalence of ASD was found to be 0.6%, and the prevalence of autism in Africa is estimated to be similar with the rest of the world. But in African context, numerous challenges exist, including shortage of resource healthcare professionals and limited awareness, cultural stigma surrounding mental health.
Dr. Aiden, I'm sorry, you're muted again.
In a study done in Nigeria, children with autism showed similar core symptoms with the rest of the world, but delayed diagnosis was common. And similarly, in a study done to describe the management of children with autism in Cameroon, found that children were diagnosed lately. And in Ethiopia, children with autism get very limited service. And according to a study, intervention programs were delivered on as-needed phases rather than the presence of structured social, behavioral, and educational interventions. And children were underserved, and the quality of care was also compromised by stigma, lack of awareness, and inadequate resources. And the rationale of the proposal was to identify the patterns of a clinical presentation, as children with autism had present with wide variety of clinical presentations, and identifying this clinical presentation will help healthcare professionals to early recognize these patterns, and when patterns are early recognized, then early diagnosis will be made, and this will pave the way for early intervention. And early intervention is associated with significantly improved long-term outcome for individuals with ASD. And this study will give valuable insights for the reasons behind delay in diagnosis. And it will also investigate the associated factors such as socioeconomic status, cultural beliefs, and parental awareness, which can lead to delay in diagnosis. And understanding this will be important for public health interventions, and the study will also describe the treatment interventions of ASD, which will pave the way for a more tailored and individualized treatment for individuals with ASD. The general objective is to assess patterns of clinical presentation, delay in diagnosis, and its associated factors of autism at St. Paul Millennium Medical College, Yekkatit 12 Hospital, and Zawditu MRL Hospital in Addis Ababa, Ethiopia, from September 2019 to September 2024. We have got 3 specific objectives. The first is to determine the pattern of diagnosis of ASD. The second is to determine delay in diagnosis and its associated factors. And the third is to describe the type of treatment interventions of ASD initiated at the 3 governmental hospitals. The study setting and period. The study will be conducted at pediatric psychiatry unit of the 3 hospitals in Addis Ababa. And the study period is going to be from September 2019 to September 2024. And each hospital has both a pediatric unit and a child mental health clinic. The study design, an institution-based retrospective cross-sectional study will be used to determine our objectives. Sample size, all patients who are attending the 3 hospitals during the 5-year period will be included. Population, the study population includes all selected children who fulfill the eligibility criteria, and all children diagnosed with ASD attending the 3 governmental hospitals over the 5-year time period will be included. Our exclusion criteria is children whose parents cannot speak either Amharic or Oromifa. Our variables, the outcome variable that we are interested to measure is delay in diagnosis in years, and our exposure variables are socio-demographics like gender, religion, ethnicity, current age, and age on first consultation, and medical history such as gestational age, route of delivery, fetal complications, neonatal hospitalization, and familial history of ASD. Operational definition, we define delay in diagnosis as the time interval from age of first concern to age of diagnosis. That is a time interval between the first age at which the parents noticed autism in their children to the time at which autism was diagnosed by a psychiatrist. And data collection plan, data abstraction tool that consists of variables of interest will be developed from patient charts and literature, and it will be used to collect necessary data from medical charts, and additional information will be collected from the parents with telephone. And quality assurance plan, to improve data quality, practical training will be given for data collectors, will be selected based on their familiarity to the subject matter, and double data entry and data cleaning through checking for inconsistencies, numerical errors, and missing parameters will be performed. Data management plan, the collected data will be entered into EPI software where the data is going to be coded and cleaned. And data analysis plan, the data will be analyzed using spaces for Microsoft Windows, and frequency and percentage will be used to describe patterns of ASD. In case of continuous variables, the means, median, interquartile range, and standard deviations will be presented as appropriate. A Poisson regression model will be used to analyze delay in diagnosis and its associated factors. Univariate analysis will be done for each independent variable, and a p-value of less than 0.5 will be included in the multi-variable analysis. And mean and variance of dependent variable will be done to check for assumption. Goodness of fit and omnibus test will be used to check for the adequacy of our model, and the p-value of less than 0.05 will be used as a cutoff point. Ethical consideration. The study will be conducted after obtaining ethical clearance from Addis Ababa Health Bureau, and written informed consent will be obtained from parents. Medical records of children whose parents gave approval will be retained in the analysis, and anonymity of the participants will be maintained by use of MRL in the research report. No other personal identifiers of the patient will be used in the research report. Access to the collected information will be limited to the investigators, and confidentiality will be maintained throughout the project. Here are our references and work plan from July 2024 up to January 2025, and our budget breakdown. Thank you.
Thank you, Dr. Eden. For this proposal, we'll have two reviewers and we'll also hear comments from the audience. So I'll first introduce our reviewers. The first one is Dr. Muluk Antasfai. Dr. Muluk Antasfai earned his MD in psychiatry specialty training from St. Paul Hospital Millennium Medical College, and he's also an associate professor of psychiatry. Currently, he is a consultant psychiatrist and CEO at Eka Kotebe Hospital, and he's also a president of Ethiopian Psychiatric Association and also founder of Bruch Medical Consultancy. This is a very shortened version of his bio. Please check his LinkedIn profile that I will put in the chat box. And the second reviewer for this proposal is Dr. Elias Ali Yusuf. He earned his MD from Jimma University in 2009 and his MPH in Hebrew University of Jerusalem in 2012, and also his PhD in medical research and international health from LMU in Munich, Germany in 2020. And he's currently an associate professor in Jimma University, as well as a co-founder and CEO of Fortuna Healthcare Solutions. So I'll leave the floor for our first reviewer, who's Dr. Muluk Antasfai.
All right, thank you very much. There is a few corrections. I am the former president of Ethiopian Psychiatric Association. Since a few weeks back, we appointed a new president, Professor Atalay. So I'm really happy to see you and to see what Dr. Eden's effort also, which is a very good proposal. And to begin, introduce a few of my comments and maybe one question. I have one question only. To begin with operational definition. If you are planning to define autism spectrum disorder based on DSM-5 revised criteria, it is going to be exhaustive work, so that I recommend to operationally define ASD as a diagnosis made as you are planning to have this document review, potentially the patient chart, of course. So that is better to define, to operationalize ASD as a diagnosis made by a treating physician and documented on the patient chart. Otherwise, if you try to define as you already planned with the same 5TR, it will be very exhaustive for you. It needs also expertise, so many investments. So I recommend you to define ASD as a diagnosis made by a treating physician. If you have any interest, you can specify that physician, residents or senior physicians or any mental health professional, you can specify and document it on the patient. I think this will be simplify your work. So this is one of my comments. And the other comment will be in your variables. It's good to consider comorbidities. It's very nice you to consider other neurodevelopmental childhood mental health issues like ADHD, so many comorbidities, very common. But of course, other medical conditions, like cardiac conditions, any anomalies, which are very good predictors of patients' morbidity and mortality as well. So I recommend to include other comorbidities, medical comorbidities in your variables. And the other thing is in your exclusion criteria, you exclude severely ill individuals, right? But majority of them may fall in, especially those whose seek medical attention, they usually have this severe form of disability. By itself, autism has this kind of presentation, so that you are not planning to interview these patients. You are trying to use secondary information so that you better include these severely ill individuals and also their caretakers. So I recommend you to revise your exclusion criteria, because the severity of illness is not going to interfere with your method of assessment. So I recommend you to revise that part as well. And it's good you to consider, management of SD in your variables. So there is also, we usually understand pediatric neurodevelopmental conditions. Of course, in any pediatric age group, we consider the child, his or her environment, and the parents. So the environment includes, family conditions, the parenting condition, as well as the school environment and the community environment. So it's good you consider the management SD, but don't forget to include the parent skill training, which is what is recommended for parents. So it has significant role in overall patients, improvement or patients' outcome. So that it's a very important variable. We are practicing this in St. Paul. We will start this in Kakota very soon. And Blackline also is practicing this parent skill training, which is very important for parents. So it's good to add this kind of variable, whether this intervention might have different role in the patient's outcome. Then this will be this might be beyond your scope of study, but it's good to consider in the management aspects. And the data collection tool, I think you have to specify which specific tool, validated tool, that you are going to use, and it should be clear that anyone who wants to execute this study should know what kind of tool they are going to use. So it should be clear. It should be self-sufficient. So it's good to include in the methodology the details, so what validators are going to use. You're going to seek information from parents or caretakers as well. You need to have an interview guide. Are you going to use in-depth interview, ZFGD, or are you planning to have a structured tool? So it should be clear, and it should be validated as well. And it's good you have an ethical consideration, because you are dealing with this vulnerable group of individuals. One question in the ethical issue is what do you do if you detected some life-threatening findings from parents, let's say, like suicidal behaviors, self-harm behaviors? If this is not even addressed in the patient's treatment, so what do you do? Because it may have some ethical implications. Other detailed technical points I can give you with the written documents. The other very important thing is you are planning to assess as your objective to assess a clinical presentation, a delay in diagnosis, and associated factors. And you also planning to describe the treatment of ASD. So you said the study described the treatment intervention of ASD that can lead to a more tailored intervention and support services that can care to individual needs. I think this objective is beyond your study, beyond the scope of your study, because in order to do that, in order to describe, treatment intervention for SD in a way that can lead to a more tailored intervention as you already planned, you need to have another type of study. The most appropriate will be systematic review. So it might involve a thorough and comprehensive search for existing literatures. You have to identify, select, critically appraise, and synthesize all relevant research, outputs, and then you may recommend, a better intervention. So I think this objective is beyond the scope of your study. So you better reconsider that. Otherwise, this is a wonderful. You identified a very good problem, so that you can tailor your methodologies and approach in this way. This is my recommendations. You can react to one of my questions regarding the ethical issues. What's your plan? You have to think ahead. And thank you very much for this opportunity. I'm done.
Thank you, Dr. Mulukan, for this nice review. And before I proceed with Dr. Elias' comments, I would like to tell you that Dr. Eden will have a chance to comment on the suggestions that are given by the reviewers and also by the audiences. At the meantime, all our audiences are welcome to write their questions and comments regarding this specific proposal in the chat box, and we'll make sure to compile everything and present it before Eden responds to the reviewers' comments. So now I'll proceed with I'll leave the floor for Dr. Elias Ali Yusuf, who's an associate professor in Juma University. Dr. Elias, you can take the floor.
Thank you. She can react to the comment by Dr. Mulukan. I'm joining to the office. I'll join.
Sure. And we are sorry that we are ahead of schedule. We are proceeding, I think, 10 minutes ahead of schedule, so it's understandable. If it is okay with you, please, Aiden, can you proceed commenting on the suggestions given by Dr. Mulukan?
Okay. I believe the best thing to do would be to explain for the parents that keeping this anonymous and not letting them know that their children is critically ill is not good for their child. And I'll try to convince them to change their mind. But if not, the autonomy still is to the parent. If they decide not to reveal the information, then they will have the autonomy, the last say.
I think there are a lot of comments and suggestions coming in the chat box. Maybe someone from us from MRL should display the comments. I see a lot of back and forth down there. So at the meantime, if you have any additional responses, Dr. Eden, if you don't have any, we will just wait for the questions to be compiled from the chat box. While we wait for that, I will display the posters that we have for today. Here. We already have. Can you see it, Dr. Eden?
Yes.
Maybe you can comment on it, and if the co-authors of the proposal if they are in the audience, maybe they can also help you, addressing some of the questions, and you can just let them in and comment on it if you can see the questions.
Okay. The second question says why choose Poisson model of regression, and the reason we chose that was the outcome variable. Delay in diagnosis is measured in years, and it's a numeric discrete variable. And in that case, we are going to first choose Poisson model, and if the assumptions fail, we'll go to the other model. It's because the outcome is measured in discrete variables. For the question that says what's the cutoff time to say delay in diagnosis, when we were reviewing the literature review, we found that an experienced physician can diagnose autism at the age of 2, but most of the time autism is diagnosed between the ages of 4 and 5. So any age, if the diagnosis is not made within the first 2 years of life, then we are going to consider it as a delay in diagnosis. We excluded parents who don't speak either Amharic or Oromifa because the questionnaire, we want to translate it. We want it to be in Amharic language. Then we are going to translate it into Oromifa, and we expect most Ethiopians to speak either of the language. So that's why if the questionnaire is not going to be in other language other than Amharic and Oromifa.
All right, Dr. Aidan, you can choose any of the questions if you feel like answering them. If not, I think Dr. Elias is ready, and you can answer to any of the comments mentioned here after Dr. Elias's comments, if it's okay with you, Dr. Aidan.
Yes, okay.
All right. I'll leave the floor to Dr. Elias then.
Okay, thank you, Dr. Eden. I think the study is very important or relevant topic because we have a rising problem of autism in Ethiopia. So it should be investigated and studied. It's a timely topic. So saying that, in terms of comparing your title and your objective and methodology, the rationale should be well studied. That means why you need this study. Because lack of knowledge or lack of practice related with delay in presentation of autism patients to hospitals. So you need to indicate that lack of knowledge or practice in the problem statement. That's one. And the second is related with your objectives. So you are going to study autism presentation in 3 major hospitals in Addis Ababa. So I think you can say that in the title also, to make it consistent with the objective, you can say pattern of clinical presentation and delay in diagnosis and associated factors of autism disorder in Addis Ababa, you can say, or in the capital city of Ethiopia. Because when you say in Ethiopia, it looks that you are taking samples also outside Addis Ababa. So that an issue with consistency. In the methodology, so you will take all the 5 years retrospectively. So how do you know whether there is a delay in presentation? So this is a question which you need to clarify. Variables. So I think you have, in the title, you have clinic part, I think pattern, let me check. Pattern of presentation, pattern of diagnosis or clinical presentation. So your primary outcome, you have two outcomes, pattern of presentation and delay of presentation. So that should be also reflected in the variables, because you have indicated delay in diagnosis as the only dependent variable. So you should show the pattern also. I think this is also comment. And for the variables, I think for your scope, it's good, the proposal, because you are a junior researcher, but you can define also the variables. For example, when you say gender, for example, is it the gender depending on, let's say, for example, from birth certificate? It may say male or female, or are you going to ask the individual, because gender is more of a social construct, sex is biological. So you may need to clarify these things, but I think for your level it's okay, but think about it in the future, or also for this research, you need to define the variables. So that's one example, gender, or for example, in the medical history of gestational age. How are you going to know gestational age? Is it from the patient? Is it from the medical history? Because different sources have different meaning. So I think it's good to think about these issues. And you have a lot of variables. I think since you are a junior researcher, you can just focus on delay in presentation and factors, and you can just narrow the scope of the study. And you have also some modeling, and I think that's okay. And I don't know if I see, and it's good. I think Dr. Mulukan already commented on that. If you have like show the relationship between variables, for example, you can put delay in presentation as an outcome variable, and mention social demographic clinical variables on one side, and make some form of diagram to show the conceptual framework. I think this is all I have. Thank you. You can answer the question.
Thank you, Dr. Elias, for your comments. Now I'll leave the floor to Dr. Aiden to answer on the comments from Dr. Elias.
I would like to thank both Dr. Mulukan and Dr. Elias for their constructive comments, and I'll take them and improve the proposal based on their recommendation.
Nice. If you want to address any of the comments from the audience that were listed earlier, I'll give you a last chance before I proceed to the next proposal.
Okay.
And it's okay then if you don't, answer any of the comments. We know that it's tough, to answer everything as you go along as a single person. So
Okay, let's
I think I should.
Yeah.
All right. I think I will proceed with the second proposal. It will be presented by Dr. Wasia Lamo, who is a third-year pediatric surgery resident in Addis Ababa University. The proposal is titled Antibiotic Resistance Pattern and Associated Factors in Pediatric surgical patients in urinary tract infection in 2 hospitals in Addis Ababa. And then for this proposal, we'll have 2 reviewers, and just like the first presentation, we'll also receive comments from the audience. Our reviewers for this proposal will be, the first one is Professor Daniel Asrat. I'll read the short bio. Professor Daniel Asrat earned his MD, MSc, and also PhD from Addis Ababa University. His MSc and PhD is in medical microbiology. Professor Daniel has been a consultant medical microbiologist for over 27 years and has published over 115 peer-reviewed articles. And he will be our first reviewer. The second reviewer will be Dr. Ephraim, a pediatric surgeon from St. Paul Hospital, Millennium Medical College. I'll leave the floor for them after Dr. Wasi's presentation. I think Dr. Wasi's presentation is ready now. I'll leave the floor for him.
Okay. Good afternoon, everyone. Can you hear me, Kira?
Yes, we can see.
Okay. Thank you. Good afternoon, everyone. Thank you for the chance I got. I would like to thank Dr. Felix for all the platform that she did to participate as, especially the junior, researchers involved in research, and that is quite appreciable, and thank you for that. I will try to move directly to my presentation. This is the title of our presentation. It is resistance pattern and associated factors in pediatric patients is urinary tract infection in 2 hospitals of Addis Ababa. This will
Excuse
be
me, Dr.
our
Wasi. Excuse me.
Yes.
Sorry for disturbing you. Can you please make it a full screen, the presentation?
Okay. Okay. Sure. Okay. Now I think it's full screen.
Yes, it is.
Okay. So this is our title, and our team is composed of 5 researchers, 1 consultant, 2 pediatric surgeon examiners, 1 physician, and me, and 1 general practitioner, and last student, Anil. So I will be working as a principal investigator for this paper. This will be our content that we are going to see today. We'll see some introduction about the topic of interest, what and why we'd like to study this topic. We'll be in the rationale first, and what that is going to be. We'll be in the objective section. The other thing is the methodology from the beginning to the end, through which we are going to go. Will be discussed under the methodology, and then forensic will begin as well. And the work plan will begin in a single step. Will be the one step, and lastly will be
Dr. Wasi. Dr. Wasi, I'm sorry for the interruption again. I think there is some kind of interference with your audio. It's not clear.
Okay, maybe I'm using an iPad. I can maybe
Maybe
use
you can
my.
switch it. All right.
Okay, okay. So I'll take.
No problem. Take your time.
Okay. Okay. Is there an improvement now? Can
Yes,
you hear me now well?
better. Yes, it's much better.
Okay, thank you. So at last we're going to see about our budget breakdown. So when I go to the introduction, as you all know, antibiotic resistance is it's emerging quite alarmingly than it has ever been in the past few years. And according to the WHO report of 2019, it's among the top 10 public health threats, and it's a topic that should be given attention to, and it's known to be more rampant in developing nations like us, unlike on contrary to the low per person consumption of antibiotics. And CDC has reported that around more than 2.8 million infections from antibiotic-resistant microbes have been recorded in the US alone, and among which more than 35,000 deaths were recorded, which is a huge figure. So that CDC has grouped around 80 microbes into 3 groups as urgent threats, serious threats, and concerning threats to just stratify them and fight or prevent this alarming antibiotics resistance. When you come to Africa and specifically to Ethiopia, UTI specifically, which is one of the common infections, especially in children, next to the respiratory tract infection, it's highly prevalent in Africa and specifically in Ethiopia. And some studies have shown that UTI is it's prevalent in around 16% of cases in some studies, and it has been shown to be as high as up to 27% in others. And in Uganda, it's close to that of 27%. And in Nigeria, there are different studies, and it shows in the range between 3 and 11%. And not only the prevalence, the resistance to common antibiotics that we're using for the management of UTI is known to be a bit worrisome. A study in Nigeria shows that up to 50% of the microbes are known to be resistant for common antibiotics like ceftriaxone, gentamicin, and ciprofloxacin, while in Tanzania, E. coli is known to be resistant in almost all cases for ampicillin, amoxicillin, and cotrimoxazole. And studies in Ethiopia has shown that resistance could range from 75 to 91% from gram-negatives for antibiotics like ampicillin, tetracycline, cefazolin, and tobramycin, and cotrimoxazole, of course, among which some of them are commonly used for the management of UTI, especially in pediatrics. And specifically in Bahar Dar, the Babegion Hospital, there was a study done around 2018, and it has shown that resistance was found to be higher for ampicillin, up to 80 up to 100%, and 70% for nitrofurantoin, which is a big figure. And despite all these figures, still currently cotrimoxazole, amoxicillin, and ciprofloxacin are the usual drugs for the outpatient management of UTI, especially in our setup, and ampicillin and gentamicin, or else maybe parenteral cephalosporins are the drugs of choice for inpatient management of UTI. So from the above figures, I think resistance is quite high for this group of antibiotics, so that it might need revision, or it might need further study. So that is what interests me to choose this topic, and what interests us to study this topic as a team, as a whole. So the other rationale is normally our clinical practice mainly based on evidences from abroad, but this is usually they vary epidemiologically across race, across geography, age, lifestyle, dietary factors, and the clinical practice by itself determines different disease entities. So studying a disease entity for a particular age group, for a particular society, is quite important whenever possible. So the other thing that I would like to point out is UTI might seem not as common, not quite common for patients, especially for surgical patients. But when we come to pediatric surgery, UTI is a huge deal, especially complicated UTI is quite common in the huge deal, because from observation, we have seen that more than half of the cases in pediatric surgery are urologic. So basically, it means that the children who are seeking our care are having abnormal functional and anatomic urinary tract. So if they are having that, it means that they are susceptible for complicated urinary tract infection. So UTI is a huge deal in pediatric surgery, and it's quite common for us to see many children with complicated UTI. So from observation, the other thing that we have seen is those patients with complicated UTI, we have seen many of them are having multi-drug resistance, extensively drug resistant, and pan-drug resistant etiologies causing UTI. It is, I mean, it's a common scenario to experience this. So studying it and structuring it into our research might help us to find a way, in a way we can use it clinically. So to the best of my knowledge, so far there is no any study in this topic in Ethiopia, despite the large number of patients who are visiting us, and not only us, throughout the country and the world, many patients seek for management of or treatment of UTI. So that is one of the rationale. The other thing is, after we are studying it, it might be used by different stakeholders, especially the Ethiopian Ministry of Health, and the other study setups like Kurambasa and Minilik Comprehensive Specialized Hospital, that are the two hospitals that are selected to undergo my study. So these hospitals and other healthcare setups might use our research, one as a baseline for further studies. The other thing may be to revise the empiric management for the disease of interest. I mean, here I'm not saying that our research will be merely adequate to change the clinical practice, but I mean, it will be a baseline, plus it might help us to call for further research using different methodology, I mean, in different setups, so that we can have different types of, I mean, outcomes, and we can entertain the drug resistance pattern for etiologies of UTI, and we will come up to a point that we either need to continue with the current management, or we need to change and have a new guideline for the management of UTI. So these are the objectives. Our general objective is we would like to assess the common etiologies and their antibiotic susceptibility in pediatric surgical patients who have culture positive urinary tract infection from October to March 2024 at two hospitals, which are Kurambasa Specialized Hospital and Minilik Second Comprehensive Specialized Hospital. So the specific objective will be, one, we would like to measure the magnitude of UTI in pediatric surgical patients, describe their etiology and their antibiotic susceptibility pattern. And apart from that, the other specific objective, we would like to establish associated factors for acquiring UTI and to identify the possible determinants of antibiotics resistance and those who are having positive urine culture. So the study period will be, as I said, from October to March 2024 in the Kurambasa Specialized Hospital and Minilik Second Comprehensive Specialized Hospital, and it will be a hospital-based cross-sectional study design. So the sample size, what we used is a single population proportion Daniel's formula. So it's calculated to be around 311, and what we used is the disease prevalence to be 24.1%, which was the latest study in pediatrics with UTI, which was done at Harar in 2023, Harar Hyotfan Hospital. I mean, pardon if I'm mistaken the name of the hospital specifically. And that is our P, the prevalence to 24.1%, and a confidence interval of 95% and margin of error of 5% was used, and we have added 10% non-responder rate, and a total of 311 was known to be our sample size, appropriate sample size with these parameters. And from our monthly report, we have seen that the patient flow at the Kurambasa Hospital is found to be 2 times that of Minilik Hospital. So we would like to share this 311 in 2-to-1 ratio, so that 1/3 of the patients, our study population, will be from Minilik Hospital, and 2/3 of it will be from the Kurambasa, so that around 104 of the patients, the samples will be from Minilik, and 207 patients will be from the Kurambasa Comprehensive Specialized Hospital. So we would like to use a convenient sampling technique till our required number of samples is achieved. So the target population will be pediatric surgical patients with UTI, while the source population will be those patients, pediatric surgical patients who visited either of the centers with either clinical and or laboratory signs and symptoms of UTI, and having no exclusion criteria. This will be the source population, while the study population will be individual patients who are selected among the source population after excluding the exclusion criteria. So any patient who visited both hospitals for the above complaints will be eligible, but those who have been on antibiotics on the prior 10 days prior to their hospital visit will be excluded from our study. But this doesn't include patients who have been on prophylactic antibiotics. Basically, patients who are having reflux and other urinary tract abnormalities could be on prophylaxis due to their high risk for UTI. So this group of patients will be included in the study if they are having breakthrough UTI while on prophylaxis. So they will not be excluded if it is for just prophylaxis. So the variables will be, the outcome of variable of interest is antibiotic resistance pattern, and exposure variables are there are many, but we have tried to group them into 3 groups. Socio-demographic factors are the first ones, and clinical factors and laboratory parameters. These are our exposure variables. So this is a concept note. We have antibiotic resistance pattern as an outcome variable, an independent variable. As the dependent variable, while we will be having socio-demographic factors, clinical factors, and laboratory parameters as independent variables. So we are going to use this concept note to finalize our research. So regarding the operational definition, we are going to use the 2010 European CDC and the CDC Joint Initiative definition for drug resistance. So they have tried to group drug resistance pattern and define them in 4 groups: multi-drug resistant, extensively drug resistant, pan-drug resistant, and susceptible. So we are going to use this definition to group our patients and label them as for which group of drug resistance pattern they belong. So this is the operational definition for our proposal and our research. So the data collection plan it will be conducted from October to March 2024 using face-to-face interview, and we are going to use trained professional data collectors, and the data collection will be done from the parents or from the guardians who will give us consent. So the other thing, apart from the face-to-face interview, urine sample will be taken for culture using the convenient method. If they are toilet trained, we might use the midstream urine. If they are not toilet trained, either way, a catheter or suprapubic puncture might be used. So we are going to use these techniques, and we will transport the urine sample within 2 hours to the lab, and the other protocols for urine culture will be followed, like checking for sterility of the culture media and the like. So we are going to use this way to collect our data. So the quality assurance plan, usually there will be a supervisor to evaluate the data collection process daily. And the other thing, language barriers will be tackled using translators. So this is how we are going to, or we will try to assure the quality of data that we are going to collect. So regarding the data management, after the data is collected, it will be coded and entered into APinfo for data cleaning. After our data is cleaned, we will go for analysis. So we are going to use SPSS version 26 for our analysis. This is app that most of, I think, our members, our team is familiar with. So we are going to use that version for the analysis. So the analysis start with descriptive statistics. We are going to describe our dependent and independent variables using different measurements. Like we are going to use the mean, the median, the mode, range, proportion, and the like to describe some of the dependent and independent variables. After doing this descriptive statistics, we will go for the regression analysis to see if there is any association between the independent and dependent variables, which is the dependent variables that we put antibiotic resistance pattern, and the independent variables that we have put in 3 groups: the clinical parameters, the socio-demographic factors, and the other thing is the lab parameters. So we are going to do analysis. The first one will be a univariate analysis, and those who are having a p-value of less than 0.5 will be taken for further multivariate analysis. As I said earlier, it's a nominal data that we are going to have when we label patients regarding their antibiotic resistance pattern, and the possible outcomes are around 4, as I said in the operational definition. So we are going to have, multinomial logistic regression analysis. But before we are going for the multivariate analysis, we have plans to do to check for multicollinearity and to check for goodness of fit tests if our regression analysis model that we choose is fit for our data, and if not, we are going to do corrections. So those in the multivariate analysis, those who are having a p-value of less than 0.05 will be taken as they are having significant association, and they'll be taken for as an output. So regarding the ethical consideration, we are going to take ethical clearance from the review boards of both institutions, which is the review board for the Ambassa Specialized Hospital and the Addis Ababa Health Bureau for meaning the second comprehensive specialized hospital. These are the references, the main references. These are not the only. There are many references in our proposal, but the main ones are this one. So our some part of our proposal arises from these references. This is the Gantt chart for our work plan. As I said, 2 of the activities are already done. The topic selection is done in July, and in August we have written proposal. And in September we are going to do ethical clearance, and we are going to train our data collectors for a day or 2 days. Then from October to March, after getting ethical clearance and training our data collectors, we will start our data collection in both research study setups. Then after collecting our data from April to May, we are going to go for data management and analysis and then report writing. And hopefully at the beginning of June, we are going to submit the final report. And this is a budget breakdown. We will have 3 groups of cost-related issues. Training costs will be the first one. Then we'll have cost for data collection, which accounts for more than 85% of our expenses, and some of them are costs from materials, and we have estimated to be around 47,931 Ethiopian birr. So our research is expected to cost this much per our estimate, so it might vary higher or lower depending on the market issues and the like, some unexpected costs. And this is the end. Thank you again for the chance.
Thank you, Dr. Wase, for your presentation. I think we have around 94 participants right now. For everyone listening, we are on the first day of the second annual MRL Research Conference. We've just heard the second proposal by Dr. Wase. It was entitled Antibiotic Resistance Pattern and Associated Factors in Pediatric Surgical Patients with Urinary Tract Infection in 2 hospitals in Addis Ababa. We'll now proceed with comments from our reviewers. Our first reviewer will be Professor Daniel Asrat. And at the meantime, all of you are invited to forward your comments in the chat box. We'll compile it and forward it in the display so that Dr. Wase and his team can answer the questions. Without further ado, I'll leave the floor for Professor Daniel Asrat.
Okay, thank you very much. Good afternoon, everybody. All the audiences participating in this conference. First, I would like to thank the group inviting me to review this paper. I want to share my comment slide. So can I share it, my slide?
Sure.
Okay. Okay. That is visible?
No, it's not.
It's not?
Now it's coming. Now it's not.
It's okay?
Yeah, it's still loading, I think.
Okay.
Now we can see it.
So is it visible? Okay.
Yes, yes, it is.
Okay. Thank you, Dr. Wase, for having such a wonderful proposal in the presentation. As the title, it mentioned antibiotic resistant pattern and associated factor in pediatric surgical patients with urinary tract infection into hospital. So just it should be. Okay, this one's the one. Just wait. I have to share it now, the slide. Is it coming the PowerPoint?
Yes, definitely.
Okay. Now, let's go to my general comment regarding this proposal. I have gone through the document page by page and have seen all the details. I think the proposal is good and scientifically sound and aspiring young researcher for this. Thank you very much for Dr. Wase. But as a young researcher writing a proposal, there are a number of topographical and grammatical errors are already there. But I made some edition for you throughout the text. It's good for you. So all blue highlighted area I have already edited and keep it as it is. But the red highlighted area needs further clarification, even it can be omitted. So go to the document carefully by looking at the colors. My specific comment regarding to the first one, the acronym and abbreviation. They need not to abbreviate some words because some words they shouldn't be abbreviated. They are already internationally known. So I put a red mark for that. You have to omit the one which I made red highlighted area. One of the weakest parts of the proposal is the methodology part. That we call it the material method. This one, it needs a major revision. And the following points should be addressed. Also, hopefully you'll answer to me now. One of the things, a little bit completely, the duration of the study. You mentioned from now your presentation from October to March 24, you said, but I think you are anticipating the next March, it should be 25. Am I correct, Wase?
Yes, Prof, you are right.
Yeah.
I just made a mistake on that, and I will take the comment. It should be March 2025.
Yeah, it should be like that. Okay. Also, in the proposal, you should write the duration of study in terms of date of start and anticipated end of the year. It has to be mentioned clearly on the proposal. One of the things also you made a mistake about Menelik second. That is a spelling a little bit odd for me, but I go to the Google also. As far as I know, it's the name have to be corrected. Do you agree on this point, Wase?
Yes, I agree. I think this one is a more formal name for the hospital.
Okay.
And I will take it.
The other thing is who will be responsible for urine sample collection and how the urine will be collected aseptically? Who is responsible? Is there any trained nurse will be involved or you are directly involved? I don't think so. You'll be involved indirectly for sample collection. So probably you'll train nurses everything, how to collect urine sample. Let me know about this point. Tell me.
Yeah, sure. I think currently I'm a training resident, surgery resident, so I will be having my own activities, and I want to be involving on the data collection process directly. But a trained nurse will be involved on that to take it aseptically and in the more convenient way for each age group of patients.
Okay.
And that is
Oh, I have plans to do it.
So you have to mention it clearly in the proposal, okay?
Sure, I will mention it.
Yeah, the other is collection of urine sample. You'll have two type of urine sample. One, midstream clean cut urine. The other way is catheter urine. I'm a little bit confused. The catheter urine is it from catheterized patient or from those not toilet trained patient? I want to know about this catheter urine sample collection.
Okay, yes. I mean, it's to mean that for those who are already toilet trained, we are going to use midstream urine. But for those who are not toilet trained, we are going to use we are going to take the catheter aseptically and take a urine sample for culture. But if convenient, suprapubic puncture might be the other way to collect our sample. And it's not to mean from a characterized patient, but it's to mean we are going to characterize for the purpose of sample collection.
Okay. Now there will be some ethical issue will be raised. Is it fair to collect your catheter urine from not toilet trained patients, pediatric patients, because the child is having suspected urinary tract infection, already they have frequent urgency, probably they will have a urine later on rather than inserting a catheter, which is an invasive procedure. Is it fair? Is it ethically sound? Please clarify on this point.
Yeah, I mean, for the sake of taking it aseptically, we are going to do that. Otherwise, it might be preferred to take it like using the midstream urine. But those children will not be cooperative to take. To give sample timely when we need it. So, I mean, after taking this into consideration, the review board might help us, and the parents might help us to give us consent to do that. So the review board's ethical approval and the parents' consent will help us. To make it sound. Otherwise, yeah, I understand the concern, but if we are not going to do that, we are not going to take the proper type of sample, and we are going to end up in a false result. So that's how I would like to deal with this point.
But the parents or the caretaker giver usually they are not comfortable about anything, about any invasive procedure, let alone urine, even if you want to store sample by rectal swab, even they are not the mother, really they will be aggressive. They don't like that type of sample condition. What I advise you, rather than to rush it to take catheter urine, you have to wait a little bit. The child probably provide urine if you have a patient. Otherwise, I'm not comfortable inserting a catheter for a child not cooperating giving a urine. So think twice before you do it. Otherwise, ethical issues and everything will be a problem. Okay, Wasi?
Sure, I will take it. Sure, thank you.
The other is this is a cross-sectional prospective study will be done for 6 months from October 24 to March 2025. Who is responsible for the laboratory procedure? Processing of urine specimen, is it the one you or the laboratory people will be assigned, or you are working together with them? I want to know that.
Okay, I think the laboratory units in both hospitals will be responsible to perform the tests, and then we are going to take the test result for analysis. Otherwise, we are not going to be involved in the analysis process. Both laboratory setups, both hospitals have a laboratory setup which has a urine culture test. So those laboratories will be responsible for the test. We are just going to intervene on analysis.
Thank you very much. You have to mention this word also in the proposal. Okay?
I will include it.
Yeah. Regarding the laboratory process of urine examination, I think
Do you think a dipstick analysis will be done before culture? Do you think microscopic examination of the urine will be done before culture? Let me know about this laboratory procedure.
One of the independent variables that we have taken is laboratory tests. So laboratory parameters will be the other independent variables. So the sample that we have taken will be sentenced for microscopy and dipstick, and it will be taken as one group of independent variables, and we will do that.
Okay, so this is part of the laboratory procedure. You have to mention it also in the urine in the proposal. Okay, microscopic examination urine, the panastic urine, it has to be mentioned in the methodology part.
Sure, I will include it.
Yeah, that is, it has to be. Regarding the urine culture, I think now we have already told me the laboratory people will be responsible for culture identification of the urine. They know how to interpret it, the definition of significant bacteria. If the child is having significant bacteria, and that is correlated to urinary tract infection. So you have to put also what is the cutoff value, everything. It has to be mentioned in the proposal because urine by nature, it's not a sterile body fluid. It contains a lot of contaminants, particularly the voided urine. It has a lot of contaminants. So by having a bacteria in the urine, it doesn't mean the child is having urinary tract infection. So there should be a calculation to say a significant bacteria. So you have to mention that word also in the proposal. Okay.
Okay, I will include that, and I will put that off for each method of data collection, and I will include that.
By the way, the cutoff value for midstream urine and catheter urine, it's different because the catheter urine means you have already bypassed the urethra, so the chance of urine contamination is less likely to be there. So the cutoff value for the two types of urine is different. Also, you have to measure it in that proposal.
Okay, thank you. I think we'll use 10 raised 10 the power of 5, 10 the power of 4, and 10 the power of 3 for suprapubic aspirate, and the catheter urine and midstream urine, and I will state that. I think I missed that.
Okay. The other is regarding to antimicrobial susceptibility, because one of your main objectives is to determine the etiologies of the microorganism responsible for UTI, their susceptibility pattern for different antimicrobial agents. And this part of methodology, it's never mentioned also in the proposal. Because at the end of the day, you have to collect the data, whatever it is, it has to be mentioned in the proposal. The method, how is it done, the type of antibiotic discs will be used for gram-positive bacteria or gram-negative bacteria. Isolate, it has to be mentioned in the proposal. Do you agree or not?
Yes, I will agree. I think they're going to use 12 disc antibiotics media for the culture here, but I will come with a specific type of antibiotics for the gram positives and the gram negatives that they are doing here. I will take that and I will add it. I will include it.
Yeah, the type of disc they are going to be used, it depends upon the capacity of the lab, what type of disc they are having. That's urinary pathogens, the gram-negative bacteria, they have their own panel of disc. The gram-positive bacteria isolated, they have their own panel of antibiotic disc. The problem is there is no uniformity of urine disc in different laboratory. You'll see the different. In the Gram-Bassa and millisecond hospital, the type of antibiotic they discarded, it's not 100% match. So that is the problem of, in this country doing susceptibility testing. So the result may be a Millik hospital will be different. It also from TASH, the result will be different because they use a different type of antibiotics. Probably they share 5 or 6 antibiotics in common. This otherwise the other side will be different. So it's up to you to analyze it, the two different hospital susceptibility testing. The other thing that I'm going to ask you is, do you think a new antibiotic, nowadays there are new drugs are coming, or already also on pipeline, already also in clinical use for the treatment of bacterial etiologies causing urinary tract infection. So do you think that discuss will be included in the sensitivity testing, like the carbapenem drugs, the monobactam drugs, the beta-lactam antibiotics, even the fluoroquinolones, the third generation and the fourth generation of fluoroquinolones are also they are available in the market. So do you think these drugs will be tested in your study?
Okay. As far as I know, especially in Dr. Ambassa, most of the drugs that we have mentioned, they will be tested from the fluoroquinolones. I don't think they will test far from ciprofloxacin, but the carbapenems, I have seen many of them included in the tests, including the meropenem. So I think some of the drugs that are mentioned are included in the test. While some of them might not be.
Okay. It's good also to screen these gram-negative bacteria for extended spectrum beta-lactamase enzyme and carbapenemase enzyme, because there are discuss also whether the bacteria having this enzyme. Is it possible? I think probably Tash, they will screen for this Military Hospital. I don't know. Do you have any idea?
I don't have any exact idea, so not to give the false information, I will just take it as an assignment, and I'll check that.
You have to check it. If they do it, it will be good. I mean, to know this isolate whether they're having this enzyme or not. So they can be multi-drug resistant or highly resistant. Strain will be isolated. So it's better to check it. It will be good.
Okay, sure. I will check that.
Yeah, because there are commercial discs available. There are discs to screen for ASBL and the carbapenemase enzyme. So it's a phenotyping method. So there is a possibility. Okay.
Okay, sure.
But in the future, also you have to think something. Really, if you are really involved in this study, even you are carefully following the laboratory result and the procedure, I would advise you, if possible, all the strains isolated from October to March 25. Is it possible to keep them in a freezer for further future study, for molecular study? Do you have a plan? Or it is beyond your mandate?
So far, the plan that I have is just a cross-sectional study, so that the sample will be used just a single analysis. But if it's not, if there is no any budget constraint in the like, I will try to extend it that way. But to be honest, the plan that I have is to just do a single analysis, culture and microscopy dipstick. But I will think of that if it is feasible.
Yeah, I'm not saying for this study. Probably you develop another proposal in the future. If the strain is kept for a longer time, you can analyze it for the future. After you complete this study, you can continue the study. That is my the way I'm thinking, not for the present study. Okay.
Okay, sure. I will take it.
The other is regarding the quality control. You have used reference strain. Why you use Pseudomonas aeruginosa? Pseudomonas aeruginosa is another group of bacteria. But for gram-negative bacteria, the presenting reference strain will be E. coli. For the gram-positive bacteria, the presenting strain will be Staphylococcus aureus. It's better to use these two reference strains as a quality control for gram-positive bacteria and gram-negative bacteria. No Pseudomonas aeruginosa, it's not recommended, because Pseudomonas by nature it has its own pattern. So even the discs are for Pseudomonas aeruginosa and Pseudomonas drugs. They take care about these reference strains. So
sure, I will take. Okay.
We have to revise this part also again.
Okay. Okay.
Let's go to the ethical consideration. Why the proposal submitted to CHSR? Because this is a mini proposal. because if you submit the proposal to the ethics committee of the Department of Pediatrics and Childhood, that is enough, because the fund you request is around, I don't know, 50,000. It's not a big fund. So why your proposal will be submitted to CHSRB? First, it has to be submitted in your department you joined, that is the Department of Pediatrics and Child Health. Once they approve it, that's enough. It's not a big project.
Okay. I think that's just for my information.
Yeah.
I was just informed that the Institutional Review Board was responsible to approve such researches. But if it's possible to get the approval, and if it is enough to proceed with approval from the department, that will be quite easier. So I'll think of that and ask for the information detail from both institutions.
So you have to consult the Department of Pediatrics why you are wasting time waiting a lot of months to get approval, because HSR only a big research having a fund internationally, or it's a PhD project like that. Yes, it will be sent to HSRB. Even the master proposal should not be sent to HSRB. Everything will be finished at the Department Ethics Committee. Okay?
Okay, thank you.
Let's
okay.
consult them. Okay?
Sure.
At the end of the day, you will have a result. We'll see it. Do you think the result of your study had any information from the previous similar studies conducted in Ethiopia? Because you mentioned there is no such study done in Ethiopia. This will be the first time, it looks like you are going to do a novel research. I don't think so. So let me clarify on this point, because a lot of papers are already published about UTI, because this is easier topic. Everyone can do it. I mean, more than 60 or 70 papers are published UTI. Half of them are pediatric urinary tract infection. So what new information you are going to add from your study in terms of the bacterial solid, in terms of the systemic pattern, in terms of risk factor? By the way, why you are going to analyze the risk factors? These are pediatric surgical patients. They have already risk factors. They are functional and anatomical abnormalities. What additional risk factors you are going to collect it? Let me know on this point.
Okay. So to start from the first thing, yeah, it's not a very first kind of research. We have around, to the best of my knowledge, we have a total of around 3 papers, which are somewhat related to this one. But one is from Bahar Dar, the other from Hawassa, and the other is from, the most recent one is from Harar. It was done in 2023. It was done on pediatric medical patients. And pediatric surgical patients are having, I think, a bit different pathologies than the medical ones. They tend to have more complicated type of UTI due to their anatomic and functional abnormalities to the urinary tract. And some of the patients are already on prophylactic antibiotics. Some of them are already exposed for different types of drugs for their, for the recurrent UTI. So there are different group of patients than the research that were done previously in the hospital that I mentioned. So the group of patients are different in terms of some of the aspects than the previous one. So that's why I said it's not. There was no any study done with the same topic in Ethiopia. Otherwise, yes, I think 3 studies were done from 2018 to 2023. Otherwise, there are some studies. What I'm going to add is that is just a recent one. Resistance, antibiotic resistance could change from time to time. So doing it and updating it will add more recent neology. And the other thing is that's in a different study setup. As I said, they were done in the regional hospitals of the above 3 cities, but doing it in these study setups is a new knowledge. Doing this research will be valuable, I think. So it will be a different finding. It will feel a different knowledge gap. So the other thing about the risk factors compared to the previous one, as I said, this group of patients are having more additional risk factors. Obstructed urinary tract, repeated use of different antibiotics, including self-medication, and the other one is being on antibiotics for a long time as a prophylaxis. So these are the different factors that will make them different from that of the previous studies. So we might have a different pattern of outcome, and this is the overall comment that I have regarding this issue.
Thank you. Now let's move to the next part. I think you have to read again. The questionnaire for parents guardian should have a title. It has to prepare in both Amharic and English version. Consult, also you have to consult also statistician. They will give you how to prepare a questionnaire, everything. So always you need a help from a statistician for questionnaire development, even after you complete the research for data analysis and everything. You have to close together with the statistician. Even the questionnaire should have 3 parts. The first part is the socio-demographic data. The second one is the clinical data. Even the third one is the laboratory data, all the laboratory procedure, the dipstick urine analysis, the microscopic examination result, the culture result, and the sensitivity result for different antibiotics. It has to be in the questionnaire. That is the way it has to be. Even the consent form for parents guardian should have a title. It has to be prepared in both Amharic and English version. So once the questionnaire is very nice, good. At the end of the day, when you complete the research, you can extract data from the questionnaire. You can easily analyze it. You can interpret your results in a proper way. So this is the thing you have to follow strictly. You understand me?
Yes, Prof. Thank you for the comments. Maybe just to add a point on this, major to the points I will take, but the questionnaire that I sent you is, I think, having consent form written in Amharic. But considering that most of the people will speak Amharic, and some of them will have different language like Oromifa, Tigrinya, and the like. So I have plans to prepare the consent form in different languages. That's why I'm going to use a translator. So apart from Amharic and English, I will also add a consent written in the language that the guardian or the parent can understand. And I will add that. I think what I sent you is written merely in Amharic, and the questionnaire is written in English. I was considering that it will be a face-to-face interview, so that the questions will be interpreted by the professional, the professional data collector, and most likely they will be able to understand the English language that's written there. That was why I didn't want to just translate the questionnaire into other language like Amharic and the like. But the consent, for sure, I will translate it into at least the basic and the common language that Ethiopians speak. And it's a very constructive comment, and I will take it.
Okay. In the reference section, reference 13 and 14, they are duplicate. They are the same. Have you seen it?
Yes. Unfortunately, I saw it after I submitted it to you. Otherwise, yeah, I have seen it, especially the researches that were done here. One of them was the research was done in Bardar. I have written it 2 times. I saw it, but I was not able to modify it. It was just submitted one.
Okay. Just I have one general question. Adult patient developing UTI, usually their symptoms is clearly known because they complain frequency, urgency, and urine color change and everything. But I'm keen to know about the clinical manifestation of pediatrics UTI. What is their complaint? What is the mother will tell you? Because most of the children may not speak, may not communicate. And what type of history the mother or the guardians tell you issues the child is having urinary tract infection?
Usually in pediatrics, urinary tract infection could have non-specific symptoms. But if they have what they're going to have is they might have non-specific, they might have fever, just fever. They might have crying during micturition. They might have anorexia, vomiting, and some of them will be also having failure to thrive if they are having recurrent types of UTI in the past few months or years of their life. So most likely the mother is going to tell he or she is crying during micturition, they are apathetic, they are feeding less, they have intermittent vomiting, and they are not doing well compared to their peers or their elder siblings. So that's what I'm expecting to hear from the guardians and the parents.
Urinary tract infections can be an acute or chronic. You know that. But your study group, do you think they have acute UTI, or some they end up also chronic urinary tract infection? So how do you differentiate between the two?
So if they are if they are going to have acute urinary tract infection, they will be having symptoms like crying during micturition, and they might have vomiting, they might have fever and the like. But if they are having chronic UTI, most likely from obstructive urinary tract and the like, they might have anorexia, they might have failure to drive like symptoms. So I think the symptoms might help us to differentiate these different types of UTI.
Okay. Do you include or any imaging data? Because some of the risk factors can be visualized by ultrasound or other imaging way. They will be subject for that, or the children?
Some of the patients, especially in our department, as long as they're having abnormal urinary tract abnormality in the function and anatomy of the urinary tract, most of them are having at least ultrasound. I think I can include it in the variables, and I can work with it. So that I didn't. So far, I didn't include it.
Yeah, I have to include it as an independent variable, plus in the questionnaire also, in addition to social demographic, clinical, laboratory. Also, if they have any imaging data that has to be recorded, probably will be give you some risk factors will be involved with that's a causative agent of UTI in this age group. No? Then you need that part also, okay?
Yeah, sure. I will include that at the fourth independent variable.
One of the intriguing question is about pediatric age in Ethiopia. What is the age of the pediatrics normally? From which age up to which? What is the definition of pediatrics?
Yes.
I'm so confused. I mean, ጎረምሳውም ህፃን የሚባልበት ሀገር ያለንበት ሀገር ስለሆነ እንደ definition of pediatrics, what is the age? Actually, የሀገሪቷ የሚኒስትር ኦፍ ሄልዝ definition ምንድን ነው?
Yeah, I mean, basically my study will be in these two hospital setups, and in these hospitals we're using the age from birth to the age of 14 years as I mean a group of patients that will be cared in the pediatric surgery and pediatrics unit. Pardon me if I'm wrong about the pediatrics and children's unit, but in pediatric surgery, though there are different different age cutoffs that they use. In Ethiopia mostly, but specifically in Tukur Anbasa and Minilik, we use the age from birth up to 14 as pediatric age group. If they are 14 and above, they will be taken as an adult, and they will be cared in the medical and in the urology unit if they are having any urinary complaint. So that is, to be specific, 0 to 14. But I will come up with the definitive Minister of Health definition for the group of patients will be taken as a child. I'll come up with that, but my patients will be from 0 to 14.
Okay, in that case, your study subjects the age between 0 up to 14. Now, your questionnaire also it has to be modified, because children with the age of 12, 14, 13, and 14, they can communicate very well. So rather than you take a consent, you can take an assent form now going to be prepared. So you have to know the difference between a consent and assent form, because you have to explain to them, they will understand you, rather than talking with the mother, with the parent guardians. You have to face with them. That's we call it assent. So questionnaire is a bit modified. So you have to modify the questionnaire if you include age up to 14.
Yes, but I think the consent is going to be from the parent or the guardian, as long as the child is underage. So, but the questions will be modified the way they fit them.
Yeah.
I will take the consent from the guardian or the parent. Okay, thank you.
Yeah. So, thank you very much. You are responding all the questions accordingly. So you are fully confident. So I will send you these comments as an attachment. So you have, before you made the final submission, your proposal to ethics committee, see the comments and accommodate accordingly. In the meantime, I will attach published articles on UTI in Ethiopia, the latest publication. You have to look at that one will give you about, particularly in the methodology part, how you write the material matters. You get a lot of information from that published articles. So I'll send to you again these 2 documents for you. Hopefully you'll end up a very nice proposal at the end of the day. Thank you very much.
Okay, thank you, Prof, for the kind comments. Thank you.
Thank you, Dr. Wase, and thank you, Professor Daniel. I think we are 20 minutes behind schedule, and I just wanted to remind all our presenters and reviewers to stick to the time, and I apologize for everyone taking more time than we allotted and we have announced. And our next reviewer will be Dr. Ephraim Nedal, pediatric surgeon from St. Paul Hospital Millennium Medical College. He will also be reviewing and commenting on this paper that is just published, proposal that is just presented by Dr. Wase. And as we have done on the previous presentation, please make sure to send us your comments on this presentation, and we'll make sure to compile and send it to Dr. Wase. And as we are short in time, we may not give him the chance to respond to them while we are in this live, but we'll make sure to compile and send it to him. And without further ado, I will leave the floor to Dr. Ephraim.
Thank you. Thank you for this opportunity. I'm sitting in for Dr. Hanna, who unfortunately could not attend this session. It was a short notice, but I was able to go through Dr. Wase's proposal document. So I will give some comments, and I will have a few questions. So from your introduction, you were mentioning some history, and you're saying the discovery of penicillin, the invention of penicillin. Mostly penicillin is considered discovery, so wording, I think, has to be changed. And also on the background information you gave on Black Lion Hospital, I think most of the data you provided is outdated. If there are informations available, latest information, I think it's better to give that background. For example, you mentioned there are around 200 physician staffs. This is, I'm sure, an outdated half as much staff physicians. Going back to your other parts of your proposal, on your microscopy and deep analysis, you mentioned about WBC and CATs. Do you have a specific cutoff value for that? When you say this patient has UTI and then you go on for culture? Is there a specific cutoff value you say? The other is on the exclusion part. You excluded those children taking antibiotics for 10 days. Can you elaborate why? Because I have some reservation on that. Because as you know, an important surgical cause for UTI is vesicourethral reflex. That's basically when the urine contained in the urinary bladder goes back to the kidneys. It's an important cause of UTI in children. And these children are usually put on prophylactic antibiotics. So if you're going to exclude children taking antibiotics for 10 days, that means you lose all these children with VUR who are waiting for surgery or on conservative management. So what's your reflection on that? My other comments is on your independent variables. You mentioned history of indwelling catheters. Not only indwelling catheters, but it's a known fact that catheterization itself can predispose a child for urinary tract infection. So I think it's also good to consider history of catheterization, not only indwelling catheters. The other thing, you're working on resistant bugs, and these bugs usually they're found at hospitals. So in your independent variables, have you considered to include the length of hospital stay of a child? And my final comment would be, have you checked which sort of antibiotics are they working in the labs to see the resistant pattern? And are they the same antibiotics? Are they doing the same antibiotics we're using, prescribing to our surgical patients? Thank you.
Okay, thank you, Doctor. I will come through some of the questions regarding some of the updates about the number of staffs and the like. The numbers I got is from the official website of the College of Health Sciences, but I understand that it might not be updated. But I thought that it's trustworthy because it's the official website. But I will take it from the bureaus and make adjustments if it is different. But that is my source, the official website of the College of Health Sciences. To come to the second question about the number of WC, I think more than 5 WCs per high power field from a centrifuged sample is the cutoff value that we are going to say when the patient is having UTI. That is the knowledge that I have, and that is what I will be using. And I will take comments if there are differences. The third one is regarding the exclusion criteria. Patients who are on antibiotics 10 days prior to their in the past 10 days prior to their presentation will be excluded. But I said patients who are on prophylactic antibiotics will not be excluded. Many of our patients, especially in pediatric surgery, are having antibiotics prophylaxis. So they will not be excluded. They will be included in the study despite any form of antibiotics they are taking if they are having breakthrough UTI while on antibiotics. So I will include them. They will not be in the exclusion criteria. The exclusion criteria works for those who are just on therapeutic antibiotics for a clinical or confirmed diagnosis of UTI. Otherwise, those on prophylaxis will be part of the study. The third one, the fourth one is about the length of stay. I have included history of hospital admission as one independent variable, but maybe the length of stay in the hospital could be also a good parameter. So I will try to be specific on that. Those who are having previous admission to the hospital, I will include the number of days in the hospital. It matters, obviously, and I will take that. The fifth one is which antibiotics they are using. I want clarification on this. You mean which antibiotics they are using to test the culture and sensitivity, or which antibiotics are they using for therapy?
Yes, what you said initially. So for which antibiotics are they studying these resistant patterns? And then are these the same antibiotics where left and right prescribing to our patients?
Which type of antibiotics they are using? I will come up after seeing the laboratory. As I said with Professor Daniel, the specific type of antibiotics that they use to test sensitivity and culture for gram-negatives and gram-positives needs specification. So I will talk to the lab personnel in both labs, and I will come up with the specific information. I don't have the written document about that, so I can't say much on it. But I will come up with that when necessary, and I can just send. I can share you. Did I answer the question, or I missed it, Doc?
No, I'm aware that you are yet to go and see which for which antibiotics they are studying the resistance and
yes, I'll come up with that. Which antibiotics are going to be tested will be a question of interest, as it has been discussed with Professor Daniel. And yeah, I have taken it, and I will see that in detail.
thank you. That's all.
Okay, thank you, Doc.
Thank you, Dr. Ephraim. Thank you, Dr. Wase and Professor Daniel. I forgot to mention that Dr. Ephraim he came with a short notice, because if you have seen the poster, we originally planned to have Dr. Hannah Abebe, an assistant professor of pediatric surgery in St. Paul, a colleague of Dr. Ephraim's. Unfortunately, she was our only reviewer, but she had an emergency, and Dr. Ephraim came after a very short notice, and we thank you for that. It was a very nice comment and a very nice presentation by Dr. Wase, and a very detailed comment by Professor Daniel. And that was our second proposal presentation. We're about to proceed with the third and the final proposal presentation, which will be presented by the team led by Dr. Brahanu Hailemariam, a cardiovascular and thoracic surgeon in St. Paul Hospital Millennium Medical College. The title of the proposal is a fast-track adult post-operative cardiac care in an Ethiopian experience. And the leader or the co-authors will be here to present the proposals. And we, as usual, will have two reviewers to comment on that, and all the audience are also welcome to forward their comments. If we have the time, we'll let the presenter address it here. If not, we'll compile and make sure to send it there. And you will also have the chance to vote on the proposals by the end of the set presentation. So without further ado, I will let Dr. Brahanu or the team members to present their proposal.
Can you hear me?
Yes, we can hear you, Dr. Abenezer. And before we proceed, I just want to quickly say that we are really sorry for our final two reviewers for making them wait longer than we expected, because we are late by 30 minutes or so, and we really apologize. Thank you, Dr. Abenezer. You can proceed.
Thank you very much. My name is Abenezer Brahanu. I'm a medical intern at St. Paul Hospital, and I'm going to present our proposal titled Fast Track Adult Post-Operative Cardiac Care, Ethiopian Experience. And the principal investigator in this research is Dr. Brahanu Hailemariam, a cardiovascular and thoracic surgeon and assistant professor of surgery. And the other team members are Dr. Merat Antene, Dr. Ruth Faisa, and Dr. Merat Taklesillase. This is going to be our outline for the presentation. So to start it off, first, initially, what's fast track surgery? Fast track surgery is a coordinated perioperative approach, which is aimed at reducing surgical stress and facilitating post-operative recovery. And it is initially was started to reduce the length of hospital stay and also to decrease the associated hospital costs with the conventional type of surgery. And it usually has three phases, including the preoperative, operative, and post-operative phase. And it requires the involvement of all the multidisciplinary team, including the surgeons, anesthesiologists, the nurses, and other healthcare workers. So our topic specifically focuses on fast-track cardiac surgery, which is, as compared to the other fields, it's a fairly new concept. Even though fast-track surgery is currently being practiced mostly in colorectal surgery, in cardiac surgery is still being started, and it's defined as the use of low-dose opioid-based general anesthesia in general in cardiac surgical patients, with the main goal of extubating within 8 hours of surgery. And there has been a lot of studies comparing the fast-track cardiac surgeries with the conventional type of cardiac surgery, and it has been found it has similar outcomes to the conventional care, but it has the additional benefit of decreasing the hospital stay and decreasing the healthcare costs. So our rationale for these studies, the morbidity and mortality of cardiovascular disease is increasing worldwide at an alarming rate, and especially it's also increasing in sub-Saharan Africa. And in a country like ours, our capacity for cardiac surgery is just starting to show promising growth. It has only started recently. And during this time of increasing cardiac surgery, one important aspect we should keep in mind is we should try to maximize the care and to get good outcomes, but also we should try to minimize the healthcare costs involved with the surgery. So fast-tracking the cardiac surgery in our setup will be very beneficial to us. But currently, the feasibility and also the status of the fast-tracked cardiac surgery is unknown in Ethiopia. So our intention is through this research to add to the, if it is feasible in our setup. So for our objectives, our general objective is to assess the outcome of cardiac surgeries that follow the fast-track cardiac care protocol performed in 4 centers located in Addis Ababa, Ethiopia. And our specific objectives are to assess the length of stay within the intensive care unit and to assess the operative mortality rate. The study settings are going to be 4 centers that are found in Addis Ababa, where cardiac surgery is currently being done, which are Cardiac Center Ethiopia, Elwizard Cardiac Center, Ethio Istanbul General Hospital, and Asthma Medical and Surgical Specialized Center. So the study is going to be conducted from starting July 1st, 2024, up to September 31st, 2025. And our study design is going to be a multi-center prospective cohort study design. For our sample size, since the number of cardiac surgeries being done currently are small, our plan is to involve all the cardiac surgeries that are being done at all the 4 setups. Our source population is going to be all patients who underwent cardiac surgery at the Cardiac Center Ethiopia, or Elwizard Cardiac Center, Ethio Istanbul General Hospital, and Asthma Medical and Surgical Specialized Center. And the study population is going to include all the patient health records of all patients who meet the inclusion and exclusion criteria. So for our inclusion criteria, we are including all patients who are above, whose age is above 18, and
excuse me, Dr. Abenezer. I think your slides are lagging behind. We still see it, but it's still behind. I think you are on the slide talking about inclusion and exclusion criteria, right? We see the sample size, the population and eligibility.
Years who underwent cardiac surgery in the above cardiac surgeries are going to be included. I think it's my network. I think that's causing the lag.
We can see it now.
Now for the exclusion criteria. So all patients below the age of 18 years are going to be excluded. Patients who have emergency cardiac surgery and radio cardiac surgery, and patients who are underweight, other complex cardiac surgery are going to be also excluded from the study. Then patients who have preoperative poor left ventricular function, and patients who had preoperatively underlying respiratory disease, and patients who have moderate to severe pulmonary hypertension are also going to be excluded. Our variables are going to be, our main outcome variables are the operative mortality and the length of stay in the ICU, and our exposure variables are going to be the age, sex, preoperative cardiac lesion, the specific cardiac surgery procedure, the presence of comorbid conditions, and the time to extubation and reintubation within the 24 hours after surgery. So when we come to our operational definition, the first thing we tried to define was the protocol that was used for the fast track cardiac surgery. So currently in our country, there is not a specific protocol which they use, but at Asthma Health Center, they're using this protocol which we adopted from an Australian study, and the protocol includes the preoperative, the intraoperative, and the post-operative anesthesia. And for time's sake, I'm not going to go into the detail, but this is going to be the preoperative protocol. This is going to be the intraoperative protocol for the cardiac anesthesia, and this is going to be the post-operative protocol. The other terms we defined was length of ICU stay, which was defined as the number of nights spent in the ICU from the date of admission to the date of discharge. The other term was operative mortality, which is days within 30 days of the first or index surgery. The other is early extubation, which is defined by removal of the endotracheal tube within 4 hours of surgery. And the other is fast track cardiac anesthesia protocol, which I showed earlier. So we are planning to collect the data using a pre-tested structured data extraction format from the patient record, and the data collectors will be the research team members, and pre-testing will be done prior to the actual data collection period to assure the quality, and the collected data will be checked visually for completeness, and errors will be identified, and the data will be coded and entered into SPSS version 26. And then we will analyze the data using descriptive statistical analysis and bivariate and multivariate logistic regression to find if the associations between the variables. And the name of the patients will be omitted from the data collected format. So this has been the references we used in this slide, the ones we mentioned. And this is our work plan starting from July of 2024, starting with proposal writing and approval, and it will conclude in September, which is September of 2025, the final research paper submission. This is our budget breakdown. So our total budget breakdown, we expect it to be around 49,170. And that was our presentation. Thank you very much.
Thank you, Dr. Abianezer. I think the presentation was lagging a few seconds behind. I didn't want to interrupt you, but I hope everybody was following along since you were not far from the slides. So without further ado, I will introduce our reviewers for this proposal. We have two reviewers. The first one is Dr. Siyum Kasa. Dr. Siyum Kasa is currently an associate professor of surgery and consultant surgeon and head of department of surgery at Addis Ababa University. Dr. Siyum earned his medical degree in surgical specialty training from Santiago de Cuba University, has been a chief of cardiothoracic surgeon in Menelik, the second hospital for over 11 years. Please check out Dr. Siyum's profile. We'll leave it in the description. And without further ado, I'll leave the floor for Dr. Siyum.
Thank you, Dr. Kirubel, for the kind presentation. And thank you, Dr. Abianezer, for presenting the proposal. Can you hear me, please?
Yes, we can.
Okay, thank you. So, yeah, it's late, 30 minutes, and the presenter has also to rush to present the paper. I mean, the proposal. I understand that. And for that, I think he has omitted some of the slides, and the slides were not, properly presented timely. It's okay. I have gone through the proposal of the team, the good team led by Dr. Brhanu Hailemariam, which is really a very nice proposal. I really like it. It's timely, it's actual. Now it's been, it's a new concept of management of surgical patient, both preoperatively, intraoperatively, and postoperatively. I have to really rush because we are running short of time. I know, I can understand there are many people, hearing the review. There are some few comments that I wanted to mention. One is in the summary of the proposal, there is some confusion. In some areas, it says that this study is done only in asthma hospital, asthma medical and surgical specialized center. And in some part of the methodology, the description of the methodology, it describes that this is a multi-centric prospective study that is going to be conducted at cardiac center, laser cardiac center, Istanbul General, and asthma. So in these 4 centers, that has to be corrected in 2 different places, both in the objectives and in the methodology of the summary. It's only described that as if this study is going to be conducted at asthma medical and surgical specialized center. This is something that has to be corrected. But I have seen the presenter has presented it, that this study is going to be conducted in these 4 cardiac private centers. That has to be corrected. The other thing is, this is with the objectives of the study. The general objective is written as to assess the outcome of cardiac surgery that follow the fast track cardiac care protocol. During the description, both in the introduction and in the summary, I have read that the study was to compare the conventional cardiac surgery management with the fast track cardiac care protocol. So I believe this is a comparative study with the conventional cardiac surgery and the fast track cardiac care protocol. This is something that should be corrected. It's say to assess, or is that to compare or to assess? Because it's a kind of comparative study, as I have understood it, as it is written on the proposal. With the specific objectives, it's so, probably they have tried to summarize it, but it's going only to assess the length of stay in the ICU and to assess the operative mortality rate. And the objective of ERAS or fast track surgery is really more than that. What about the morbidity? What about the complications? What about the other factors, the other advantage other than, cost effectiveness and early discharge? There are many, many advantages of ERAS protocol or fast track protocol nowadays. So this is something that has to be revised by the researchers. For instance, the aims of ERAS is preoperative optimization, which should really think about the preoperative nutritional status of the patient, smoking cessation, physical activity of the patient, patient education, multimodal anesthesia, early oral intake, early mobilization, optimization of fluid management, and minimally invasive techniques, including in this particular case, for example, pain control. What about the epidural anesthesia, which is very important for pain control, which is management of pain, which is one of the most important pillars of ERAS management, and post-operative monitoring and care and early discharge planning are things that we have to consider in this ERAS protocol. So this is something that we have to revise. The other comment that I want to have in the sample size calculation, as I can see in the proposal, there is no sample size calculation at all. The very brief comment there, which is not complete for the study which is going to be conducted. One, we have to look for justification of the sample size. Is the sample size appropriate? It's a prospective study, I understand. And mention the statistical consideration of that sample size is very important. Population characteristics is very important. Describe the characteristics of the population is very important. The methodology, that means to explain the methodology you have used to determine the sample size, has to be stated there. And the expected outcomes also, discuss how the expected outcome of the study will be with the chosen sample size is something that we have to see also. The accuracy of the sample size, the consideration ensures that the sample size is large enough to draw meaningful conclusions is very important also. What's about the future directions of the sample size, and to ensure also the ethical consideration. The other comment that I wanted to make in the proposal is about the ethical consideration. The only thing which is written there is that the names of the patient is not going to be disclosed. If I'm not mistaken, that's the only thing that I have seen written in the proposal. First of all, the informed consent outline how informed consent should be obtained, and the confidentiality, if the participants are voluntary, minimization of harm, what is the benefit of the study, deception, conflict of interest. You know, this study is going to be conducted in 3 private hospitals, and the cardiac center also is a semi-private hospital. So if there is any conflict of interest, disclosure of any potential conflict of interest has to be stated there. How is going the data to be handled is something that has to be stated also. And the approval and oversight, at least nothing has been mentioned about the approval of this proposal. How to commit to the reporting of the results to the study accurately and transparently without manipulating or withholding data to suit a particular agenda, this particular agenda. So reporting of the result, how is this reporting is going to be, is something that has to be, you know, stated in the ethical consideration. And these are the major things that I wanted to. Okay. The other thing that I haven't seen in the proposal is what about the conceptual framework? What about the conceptual framework, which is something that I haven't seen there? And finally, you know, during the exclusion criteria, patients below less than 18 years old has been excluded. My question is why? Why is that? Is there any reason for that? So these are, in summary, the things that I have seen. Probably if I have forgotten some, I will come again and try to remind you. Thank you very much. That's all for me.
Thank you, Dr. Siyum. It was nice comment. I think Ebenezer, you can respond now or wait until the second reviewer has commented on it. And I would like to remind all our guests that we will send a written report from the reviewers to all the presenters. So this will be a brief comment from the reviewers here. So I'll let Ebenezer decide to respond now or wait until our second reviewer comments.
Just to mention some few points. The first one, yeah, there was some inconsistency on the summary part and the other. That was our error while editing. Initially, our plan was to do it only at one center at Asma, and then we added the other places with communication with the medical research fund. So that was why that mistake happened. The other also, the comment given to us on the objective part, yes, that was also an error, and we will take the comment kindly. On the specific objectives, it was mentioned that we only included 2 objectives on our structured checklist for the card. We have included almost all aspects from starting from the socio-demographic characteristics to the preoperative optimization and the post-operative factors. But we only wrote on the specific objective our main 2 outcomes we were going to assess, but we still plan to evaluate the other factors which was mentioned by doctor. So this is why. The other is on why were the patients less than 18 years old excluded. So when we started the proposal, on the pediatric cardiac surgery and on the adult cardiac surgery, there's going to be significant difference on the indications, on the outcome, on the length of the procedure. So our plan was to do only on the adult cardiac surgery. So we excluded pediatric surgeries from the cardiac surgery. So that's why we excluded those. The other comments, yes, we will take them kindly. Thank you for the comments.
Thank you, Dr. Ebenezer. I will now proceed with our final reviewer, Dr. Addisu Taddese. Dr. Addisu Taddese earned his Bachelor of Science in 2009 in Healthcare Administration and Management, and his Bachelor of Public Health in 2012, his Master's of Public Health in 2014, and his PhD in 2019. He also has a Master's of Science in Data Science in 2023. So Dr. Addisu is a public health researcher and an independent consultant. I'll now leave the floor for him to comment on our final proposal, which was just presented by Dr. Ebenezer now.
Thank you, Dr. Krube, and I appreciate the presentation from the Dr. Ebenezer, and I also have a respect for Dr. Siyu. So, can you hear me?
Yes, we can.
Okay, thank you. I really appreciate the title, Fast Track Adult Post-Operative Cardiac Care. Maybe it's telling us a lesson about patient experience. Title-wise, topic-wise is an interesting. I share the same concept or same idea how published with the first reviewer, but and even presentation-wise, I'm happy with the presentation, except with the crowded PowerPoint and lack of some consistency in citation within the PowerPoint. Maybe a referencing and some of PowerPoints were of copy paste. I think they can be edited and then next or in another round of presentation. Having said this, I can go through. I have reviewed the proposal and the maybe novelty, maybe the and the reasons of the title, the idea. I really have an interest toward this topic. But procedure-wise, or from research or scientific perspective, had of some issue. Maybe from the title itself is a bit different from the what was documented throughout the entire proposal. Maybe if you look over this title, fast track and then post-op cardiac care, then saying Ethiopian experience, it seems something that a review than some a finding or a report from the comparative analysis, even from prospective cohort analysis. It doesn't look like with that. Maybe if they can modify this and work over like a comparative analysis of the fast track versus the traditional or normal procedure. Maybe in that way they can say cohort study in the may work out. Otherwise, with this one, it seems like a review or nine, and maybe body of knowledge from reviewed articles or from the clinical guideline and the like. But the decision is up to the authors. But it doesn't look like of what's documented throughout the entire proposal. Throughout the entire proposal, maybe Dr. Kubert, if you can allow me, maybe I need a bit discussion with the presenter, maybe for some critical issue.
Sure. We are still short of time, but if it is critical, we will move.
I'm not going like
Sure.
Dr. Kubert, if you're hearing me, why don't you try if this is a prospective study, then you can access the patient while you're going for reviewing a medical chart than actual finding a patient, an actual patient, maybe.
Dr. Ebenezer?
Please, all the informations we need, the extubation time, the protocol used for each patient, the anesthesia they used, the preoperative preparations are going to be documented on the chart, and we're not going to interview the patients to get those informations. They're going to be documented on the chart, so we're going to take our data from the charts.
Thank you for the reaction, but what the idea is, if you really want to conduct the research and real impactful research, maybe this is the opportunity for you to go through the actual participant. What the primary purpose of fast track, comparing fast track versus the conventional one is to see whether there is a change, whether there is improvement, there is an advantage, there are of comparison for satisfaction, comparison with the reduction in the hospital stay, morbidity, mortality, and all things that have been said by the previous or first reviewer. So if these are the critical reason why we're going for the fast track, I don't think you can proceed in that way. From scientific perspective, I don't think personally. If I have tried looking over previous studies in the same topic, like those which compared the fast track versus conventional procedure. They conducted a cohort, and it seems even experimentation. And at the end of the day, they compared all cons and pros of those two approach of for making a surgery. So if that the case, maybe I recommend you to go for a patient, then still for experiment of investigation, so that the all importance or advantage of this fast track can be measured by this study. So there is no further study in the same topic with an experimentation or in the other way. Those of comments on inconsistencies in setting and some other has were of said, I'm not going through. And maybe the other critical question that I actually is not a question, it should be of a comment. As if this is a comparative study, I didn't say anything about control groups, like of those who pass through the conventional surgery. Then the method, the objective, the title should have of those should consider those groups. That's also a comment. I think they can incorporate this in the final revised proposal. The other studies on same topic, they compared for cost effectiveness. I think I have seen on the introductory part, the cost effectiveness is one of an advantage for the fast track. But I didn't see any analysis mechanism. I didn't see any presentation measurement to related issues with cost effectiveness. Still, from a medical record, I don't think they can measure this as well. The other thing, the other importance or purpose of this fast track is like improving patient satisfaction. It's been said in the introductory part, but didn't see on those methods and the like. And having this, there are of assuming that there are the outcomes within the stated proposal, like of length of stay in the hospital in the ICU versus as well the mortality. If having those outcomes, I don't think how they can measure or they can identify that they can.
Dr. Adiso? I think we've lost connection with Dr. Adiso.
Yes.
We've lost you for a second. I'll leave the floor for you.
Is that working now?
Yes, we can hear you.
Okay. So the first outcome within the stated proposal is not my recommendation. There are two outcomes or two objectives. Maybe the mortality and thus alive days within some elapsed period or stated period, and average time to stay within some within the ICU or in the hospital. The other outcome maybe as stated. How are you going to compare these outcomes at the end of the day, either for the outcome of days or mortality? I didn't say. I think regression wouldn't compare that. Logistic regression wouldn't compare that, and even average time to discharge or average stay in the ICU still that's not something that fit for logistic regression. So methodologically, I think that they need to go through or to revise maybe, and there are of things for data entry. Maybe I didn't see. Space is not appropriate for data entry. That's for analysis. But procedurally, if I was expecting like there are of two groups, those who went through the conventional surgery versus fast track, then how they're following, how they're measuring, how they at the end of the day how they're comparing everything, either satisfaction, the cost effectiveness, mortality, then length of stay in the ICU or in the hospital. They can compare at the end of the day. I was expecting that clear flow from presentation, not from proposal, but it wasn't fortunate for us to hear that. But they can make it in the revision maybe in the future. But what the criteria to classify patient to the control to the conventional versus the fast track still does that raise some issues like of ethical issues, maybe another issue. The other thing is the same concern. Maybe he tried the Dr. Ebenezer tried to react for the exclusion criteria. If we're having comparative group and age of everything, if you included both group that have nothing in the outcome, that impact nothing on the outcome or in the whether those of young people do have a difference from the adult. If you mix in both group, I don't think the relevance of excluding this group. Even I do have an objection over most of some of the exclusion criterion. If we have compare both group, then the problem is if you are including in some group and excluding from the other group, that matters or that may raise the issue of problem or inconsistency, like having a comparative group of comparable individuals. That's the only problem that within the in the comparative study. Otherwise, I'm not looking over. The other thing is in data quality issue. There are of procedures this fast track as well. The conventional surgeries are expected to be performed by different surgeons. What are the mechanisms that you're assuring if they are of a difference or a variation in across across the surgeons? Like inter measurement or inter operation variability is one of critical issues, or how you're assuring them. The reliability issue I didn't see. Maybe validity issue also, whether the intervention brought the impact, whether you can make an inference based on the finding, or whether you employed appropriate statistical analysis. So that this all are of missed from the entire proposal, except the novelty and the idea, the recent idea. Most of things are of, I think, and maybe reacting to some of comment would affect the quality of paper. Maybe that's my understanding. And if you need a recommendation, maybe like making it a cohort, and maybe if even you randomized control trial in the future by yourself, maybe you can look for sort of fund, and maybe you can proceed with that, maybe to make it like impactful research. Otherwise, by its current status, I'm in fear of like recommending this proposal even for further. Very few reference were of outdated. Maybe you can work over. Maybe let me stop in here. Thank you for listening.
Thank you, Dr. Addisu, for your detailed comments. I'm sure Dr. Ebenezer and his team are grabbing everything and preparing a reaction for that. And I'm sure that you'll send the official report and grading for the proposal. And at the meantime, we'll drop the link to public voting for the best proposal. While it is going on, I want to remind you all the proposals. And before that, I want to thank Dr. Siyum, Professor Daniel, Dr. Elias, Dr. Muluk, and Dr. Ephraim and Dr. Addisu, all our reviewers, and also all our presenters, Dr. Eden, Dr. Wase, and Dr. Ebenezer, for taking your time, and all our guests, everybody, department heads, CEOs of hospitals, and distinguished researchers with over 100 peer-reviewed publications. Everybody, we're happy to have you here, and we're really sorry for keeping you waiting for 30 plus more minutes. And as you are voting for the best proposal down the chat box, you can find the link there. I will show you. I'll go through the titles in case you have forgotten it. I'll go through the titles of the presentation for all the three proposals. So we'll have it open for 5 minutes. So we'll close it in 5 minutes. So the public voting will be there for 5 minutes. So the first presentation was by Dr. Eden Tafari. It was about pattern of diagnosis and treatment challenges of autism spectrum disorder at government hospitals in Ethiopia. It was reviewed by both Dr. Mulukan and Dr. Elias. And the second paper proposal was by Dr. Wase Alamo. It was about antibiotic resistance pattern and associated factors in pediatric surgical patients with urinary tract infections in 2 hospitals in Addis Ababa. It was reviewed by Professor Daniel Asrad and Dr. Ephraim. And the last presentation, the proposal was presented by Dr. Ebenezer. It was titled Fast Track Adult Postoperative Cardiac Care, an Ethiopian Perspective. And it was reviewed by Dr. Siyum Kasa and Dr. Addisu. So while it is going on, I would like to share with you a presentation showing some of the posters that are currently presented in MRL's archive. I also want to remind you that it's a very nice way to present your work, especially your final graduating thesis work, especially from medical school. We know most of us do not have the chance to publish in a peer-reviewed journal. So this will be a nice opportunity to at least get a recognition from your work that you've done as a graduating thesis. So you can submit your papers, you can follow the calls in the MRL platforms and submit your papers, get it commented, prepare your posters, and get it published and presented in one of the conferences like this that will be held in the future. So these are some of the pitches that I would like to show you. So I think we're up. Our 5 minutes is about to be finished. I will wait 2 more minutes and I'll just shut up and leave you alone on the voting.
Dr. Kruger, can you send our evaluation report to you now?
I think we can share it after the conference, and we will send it to them as well via email. We can share it.
So I can share you now.
Okay, sure.
Okay.
Thank you. I think our time is up. So before we close up, we'll share the link for participation certificate down in the chat box. You all can find it there, but bear in mind to fill it up within the coming 5 minutes. So it won't be active after that. You can fill it in for all participants. I just want to thank everybody who come here to present their work and who come here to review the works as well. And I want to thank all our reviewers for being here and for being accessible, because we didn't have these chances. And I really want to thank Dr. Tigist for taking this initiative and for creating this platform. I hope everybody will take advantage of this. Every medical student, every junior researcher, and every medical graduate will take advantage of this. And again, I want to thank all our participants down here. And this is only the first day of our 2-day conference, so we'll have a second day conference the same time tomorrow. And I want to thank everybody who participated here. Fill out the forms to get the certificates. And with that, I will close today's session. Thank you very much.
Thank you. Have a nice day.